mentioned earlier that I was going to be talking about the cardiovascular risk assessment, and that is new HCPCS codes G0537 and G0538. It's really exciting to talk about this because it's that atherosclerotic disease is common in our patient population. The question that came in was simple. I'd like to learn more about the 2025 Cardiovascular Risk Assessment and Management Services, the G053 and G0538. So I'm really glad that they did ask this question. Whenever we get new codes that are going to allow us to better take care of our patients, we want to make sure that everyone, the coders as well as the clinicians, have a good understanding of what it entails to be able to use this code. Now, the background for using this code is that we're looking for atherosclerotic cardiovascular disease. And if you want to abbreviate that, it's ASCVD. And again, this is incredibly common on a global standpoint. It isn't just the people that are, say, have comorbidity factors that would compromise the heart. It also is people that have a family history. Obesity is so common, which contributes, as well as smoking. All of these are factors that make these people at high risk. But also, if you live long enough, your vascular system is going to get a little clogged up. It's like leaving a glass of water out on a windowsill. And as it ages, you get that crust on the side. So that's what atherosclerotic cardiovascular disease is. But it's really important that if you do have this, we have early detection, because this particular diagnosis can wear on the rest of the body, not just the heart. And so the idea is, how do we promote people being tested for ASCVD early? And again, this is the reason these type of codes and this thought process for plan of care comes about, is because the coding that we've done for years that allows us to see the long-term process of a disease. For example, think of breast cancer. Why do we know so much about breast cancer now, and that early intervention is really important by getting mammograms? Because of the statistics that are captured in the coding. That's what we do, guys. This is one of those areas that we know is very prominent statistically. And they also know that early detection changes the outcome for these patients. So on January 1st for 2025, CMS added these two new G codes to the Medicare physician fee schedule. So what that means is they allowed it to be reimbursed. And that supports the reimbursement for atherosclerotic cardiovascular disease and a risk assessment and management services. While both codes may be used to report an evaluation of the ASCVD, each is intended for a distinct application. And that's what I'm going to explain to you right now, because they are not the same. They are different in the way that we use them. So first, let's look at G0537. The purpose is it's used for an initial assessment and detection. That's key. It is also the administration of a standardized risk assessment. And that's going to be a form that's going to be filled out by the patient and the clinician. This is required to be evidence-based for ASCVD. Now, we do have a couple suggestions of these tools, but you can't just use the G0537 without stating that this tool or this assessment was applied. It's not going to be reimbursed without doing that. So who's eligible to be tested for this code to be used? It's any patient with a current or without the current diagnosis. So the patient doesn't have ASCVD It hasn't been diagnosed with them. It won't be on their problem list, but at least one predisposing condition. And that there's a lot of them. The examples they're stating is high blood pressure, high cholesterol. It could be a family history of this diagnosis. So again, we're not just going to screen everybody. There has to be a predisposition in some format, and they cannot have had that diagnosis in the past to use the G0537. Now, when we bill this code, this G code, it can be billed once every 12 months per practitioner per patient. So let's say the PCP does it, finds out that the patient needs testing done, they can use it. But if they send them to the cardiovascular specialist, they could use it, but not if they are given the diagnosis by the primary. So that's the key. It can be used by more than one practitioner in a year, but you're going to have to be very careful about that because there's stipulations for using those. What most likely will be happening is that either the PCP will do it or the specialist will do it, one or the other. And I suspect the PCP should probably do it first. Now, the tools, what are we going to use to do these assessment? You can use any of the tools that the American College of Cardiology puts out, for example, or there is already an ASCVD risk assessment or American Heart Association preventative tool. That's the one. There's not only is there the American Heart Association, there's another one that escapes me. You guys might want to put in the chat, but I think there isn't a list that says you have to use one of these tools, but it has to be a reputable tool. You can't just use AI and come up with a tool and say, this is the tool that I'm going to use. So that's real important to know. How are we going to differentiate the G0537 with the G0538? It's the purpose. The purpose for G0538 is for ongoing management. Okay, so the patient has the diagnosis. The management services for the patient at intermediate, medium, or high risk of ASCVD. And the services that are going to be included in this is medication management, blood pressure control, cholesterol management, and smoking cessation. Now, there is another code for counseling for smoking cessation. I think we've probably educated on that, but you might want to do a little research. If you want more information about that, feel free to drop that in our topic requests because it also pays out in addition to the G0538. Smoking is a huge contributing factor to this diagnosis. Now, what's our patient criteria? So patients without a current ASCVD diagnosis, but identified as an at-risk via assessment. So both of these codes are patients that do not have this diagnosis. So one is the purpose is the initial to see if once a year the patient is at high risk. And then if they are at high risk, we're going to be able to use the other code, the G0538, to manage the diagnoses. So that billing purposes are going to allow us to use this code every month, up to every month for ongoing management. So what's the key? The key is to identify the people that are high risk. The second key is to be able to manage to make sure that we maintain that patient's health and that they don't trip into developing the ASCVD. So let's again look at one is an assessment, G0537. Remember that. You can only use it once every 12 months. So that means you have to have documented when the assessment was done. If it was done at their annual wellness visit, then that would be, say, they had theirs done on their birthday. So my birthday's in July. If I had an annual wellness visit in July, they could do it again in July or after that. Now, management, the G0538, you can bill that per month. That doesn't mean the patient is coming in every month unless you're requiring them to do it for this service. Most patients don't come in every month. However, if they are seeing the cardiologist for a specialty due to another diagnosis, or they have a reason, say diabetes or other things that's being checked, then they could. But know that it could be billed every month. And then eligibility with G0537, it's for risk assessment. Is this patient predisposed? Is this a patient that needs to be followed to make sure they don't develop this diagnosis? Or with the G0538, it's the management of those that are identified at high risk. Both of these are not used for patients that have the diagnosis. If you've already got the diagnosis, there's no sense in doing an assessment or managing to look for the diagnosis. It would be redundant to do. The implementation and best practice is to ensure that you have accurate patient eligibility and documentation. That's where that CDI component comes in. We want to make sure our clinician providers are documenting that the patient does not have the diagnosis, but what their high risk factors are. They have a family history, they have hypertension, and they are smoking. They're going to use standardized evidence-based tools for assessment, not one that's just made up in the office as an identification tool. It has to come from a reputable source, and there's plenty of them out there, and you can use whichever one the clinician chooses to use in their office. You're going to engage in shared decision-making for management plans. That means that if it's the PCP that's doing the eligibility, and it is the cardiologist that's going to, or the vascular specialist that's going to follow up with them monthly because they're already seeing them for another diagnosis. Again, it's a team process, and we want to make sure that everybody's talking to each other, and that's where documentation plays a significant role as well. Now, ultimately, we're going to monitor and revise the plan of care as needed. So let's say we find that the patient is at high risk, but 6 months later, they see that more testing is done by the cardiologist or a vascular specialist. And yes, they've developed this diagnosis. That's a stop on these two codes, and it goes into, say, full-time treatment with the cardiologist or the specialist. And then you'd want to go back and let the other clinicians that might be applying that code for monitoring that they have a diagnosis, update the patient's record and plan of care, because problem lists never get updated like they're supposed to. So proper communication for the plan of care will help. Now, as we wrap up, though, what we want to really truly do is enhance the cardiovascular care by using these two codes. And you can see how these two codes could be a game changer in the outcome for patients who are high risk. So the G0537 and the G0538, they're going to work together, and we've got really a full circle approach to fighting heart disease and improving the patient's health and outcome. The G0537 focuses on spotting the risks early, because early detection is truly the key, with the G0538 being support ongoing care with follow-up. Now, together, these codes support that comprehensive care for atherosclerotic vascular disease. Every time we have an early risk assessment and management, then we can significantly improve the patient's outcome. That's the goal from the beginning. From when we are monitoring for a new diagnosis based on having many comorbidities or high risk factors, to prevention, education to the patient, medication to stave off these diagnoses that can really truly change a patient's longevity and quality of life. The resources, if you want more information about these two new codes, is to go to the Federal Registry rule, and we have that link here on the slide. The two suggested groups that you go to, though, probably the number one would be the American College of Cardiology and ASCVD Risk Estimator Plus tool. I would say that's who, if you're going to implement this in your office, go back and tell them that this is available, that would be a standard form that you could start with. And I want to wrap up by saying that it's important that we continue, as we learn this information, new codes, that we go back to the office and share that with everybody on the team, because new codes sometimes, especially HCPCS codes, don't always get picked up and educated on, like the new CPT codes and the ICD codes as we go into the new year. But we, one, don't want to lose revenue for the hard work that our clinician providers are doing. And then in addition, we want to make sure, ultimately, the goal is to keep our patients healthy. So practical coding and case study. We've got some questions. I don't know if a case study was put in here. I don't think it was, but let me just give you one real quick off the top of my head. So let's say we have patient A comes in and they come in for their annual wellness visit because they just turned 65. The year is 2025, and they have a family history of heart disease, a family history of, let's say, digestive cancer, and a diagnosis of obesity and hypertension. Which one of these codes would be appended for their annual, that you could use with an annual wellness visit for that patient? Would it be G0537 or G0538? What do you guys think? And go ahead and put it up in the chat. And then while you are doing that, we'll get ready to do our quiz.
We did have a question that I thought we could answer before we do the quiz.
Sure.
This is from Karen. When you were talking about the code, she said, isn't that kind of like G2211?
No. Okay. It is similar in
Come
that.
to your camera, because you keep disappearing.
Yeah. I noticed that when I put my hand over my face, it went black, like I was Casper the Friendly Ghost or something. G2211 is stating that you have a ongoing relationship with your patient. This is the provider saying that, and that they're managing one or more chronic conditions for that patient. And you would append that every time they are seen by you, the clinician. Okay. This, though, is different because you're specifically looking for a diagnosis that's identified with the code, whereas the G2211 allows you to follow a patient that already has these diagnoses. The diagnosis is identified, the patient has it, and that you're the main person that the patient goes to for that chronic condition. That was started last year because CMS decided that clinicians were honestly not getting paid enough, reimbursed enough for the ongoing care of chronic conditions. So the G2211 gives them about $15 to $30 more every time the patient comes in, depending on who the payer is. So it's an ongoing relationship for identified chronic conditions, whereas this new G code, these are to identify, to prevent a diagnosis. So two separate things. That's really good. A really good question, guys. I also looked up to confirm, because when we use G2211, you don't use a modifier with that, right? You just give that. But if you do other, say, assessment procedures and stuff like that, sometimes modifiers are used. And so I just went to double check that they weren't going to have us append a modifier, which I didn't think they would. But I thought because you guys are so savvy, you might ask that. And you don't append a modifier. It's going to be used just like the G2211, but following how you can use it. One is once a year, one is up to every month. And you guys are right. Gina, Samantha, April, G0537 for the one that I suggested. So let's go look at our quiz. The first,
I did want to say too about the G2211. That's an add-on code to like E&M codes. And so the question about being able to bill both, the codes that Alicia went over, they're not like E&M equivalent codes. So you wouldn't code the two together.
And that's another reason why I looked to make sure there wasn't a modifier, that this wasn't like classified as an additional procedure type thing you're doing this assessment, and it's not. So the first quiz question is, which of the following is required element when billing G0537? Patient consent form. Am I on the right one? Yes. Use of a validated ASCVD risk assessment tool, referral to a cardiologist, or hospital admission. And it looks like you guys nailed it at use of a valid tool. And again, we shared probably the number one go-to, the Heart Association, I would say. Our next one, G0538 is primarily used for which type of patient? A patient with no cardiovascular history, a patient undergoing surgery, a patient diagnosed with ASCVD, a patient receiving immunizations. That might be a little tricky. Which is the G0538 is primarily used for which type of patient? So narrow it down. The G0538 can be used every month, and it is a monitoring, right? So you're not doing it once a year with that assessment tool. You're following and monitoring assessing the patient in each month.
The answer said ASCVD. Is that wrong?
It is not a patient. You cannot have a diagnosis of ASCVD because you're looking for the diagnosis. Remember, one of the points is you can't have that diagnosis, or otherwise it's not preventative medicine. And that's what this is.
Okay. So
the first code is for once a year, acknowledging, yes, this patient's at high risk. We better monitor. The second code is, hey, we're monitoring up to every month. So it would not be a patient diagnosed with the code because then it's redundant. And yeah. And a patient with no cardiovascular history, if they have no cardiovascular history, then they're not a candidate to monitor, right? Because they have none of the ongoing hypertension, smoking cessation, or any of those diagnoses. So why would you be monitoring them for that? A patient undergoing surgery, yeah, you could do that tool if a patient to see if they're at high risk, but really it's D, because a patient receiving immunization, because they're coming in for a routine preventative medicine, and then you can go ahead and do that assessment because they were identified as high risk. Really, that's a tricky question.
Yeah, it wasn't a good one.
Okay, so the next one, how often can the G0538 be billed? Once a year, once per calendar month, once per hospital stay, once per week. And you guys are almost right. No, you guys are not. It's once per calendar month. Did anybody pick that one? Oh, I'm sorry, they did. I'm sorry. I only saw once per year and once per hospital stay marked.
Oh, it was. They just answered.
Okay, good. Yes, it's once per calendar month. It can be used per physician. So think about this. You could see this happening is that they were listed as high risk. They used the G0537. Oh, I'm at high risk because I have hypertension and a family history, let's say, and high cholesterol. Now, they go in next month and see their cardiologist. They can bill the G0538 because the cardiologist is going to do that assessment. And then 2 months later, they go in and see their PCP. And the PCP can bill this again because they're checking them again to make sure that they don't have the diagnosis yet. It can be billed up to once a month per clinician ongoing. What is the average Medicare reimbursement for G0537? We didn't talk about that, but if anybody, no, I can go in to find a code. I almost thought about this, almost did. Let me just bring up my find a code because I can go in and look at it with that. Let me sign in.
Let me 1844.
G0537. So what happens in find a code, which I'm showing my screen if you want to see it. Hold on. I'm going to share right there. This is just another reason why I like find a code. It's so easy to find. I'll quit putting my hand in front of my face.
I don't see your...
Okay, share screen and this one. All right, so here's the new code. It tells us that it came in January 1st. Then I can come down here to all of these great additional information. So if I want information about the code itself, I can get all of this information, but that's not what I'm looking for. I'm looking for fees. So let's say non-facility office visit. Medicare allows $18.44. Looks like it's about $18.
$18.44. That was answer C.
That's great. Okay, I'm going to stop sharing. There we go. Great, great. And then do we have another?
We have one more. It should be very easy. Oops. Oh,
no.
My mouse just died. Hang on.
Mouse died. Mine, I don't have another question. That was the end of my slide.
Oh, okay. Get one more. Oh, no, you're right. That's the last question. All right, we're good. I guess there was 4 questions in there.
So I hope you've got a better understanding, you guys, and go take this back to your office and let them know, show them that you've got the initiative, you're taking ongoing training so that you can establish yourself as a leader by the research that you're doing. It's important to do that. Or go back to any other organizations that you're a part of and offer to do a presentation on these 2 new codes. That would be brilliant.
Yeah.
Looking for medical coding, medical billing, and risk adjustment education? Learn more at cco.us.